Hello, I'm Dr. William McGuire. I am a medical oncologist, but have spent the last several years treating exclusively female pelvic cancer and specifically ovarian cancer. And I wanted to spend a few moments today to discuss the question which many patients have. You've already had chemotherapy for your ovarian cancer, and now the question I'm sure that's foremost in many people's mind is, what if my ovarian cancer comes back? So how commonly does this occur? Well, first off, the chance of the tumor coming back, which we call recurrence, is dependent on several factors, including the initial stage of the cancer. I'm not going to go into staging. I think somebody else has covered that, but the vast majority of patients actually have stage 3 disease. It's also dependent on the amount of tumor the surgeon is able to remove and how completely and rapidly the tumor responds to that initial chemotherapy. So broken down by stage, if you have stage 1 cancer, and that's about 20% of patients, there's still about a 10% chance that cancer is going to come back. Stage 2 cancer, which is cancer that is outside the ovary but hasn't gotten out of the pelvis, and some of us don't even believe that this stage exists. The chance of the tumor coming back is around 25%. The vast majority of patients at the time that they are diagnosed have stage 3 cancer, and the chance of the tumor coming back after chemotherapy varies from 50% to 80%, and I'll go into a little bit more detail about why I've put such broad things there from 50 to 80%, and that depends on other factors. And stage 4 cancer, which is cancer that is spread outside the abdomen to other organs, most typically to the inside of the liver or to the lungs, the chance of the tumor coming back if you have stage 4 cancer is about 95%. So obviously this is a common occurrence, and I think I don't want you to spend a whole lot of time dwelling on this and worrying about it. But it's still important to know that it does come back and that there are things that can be done if the ovarian cancer comes back. As I've said, most patients have stage 3 cancer, about 70-75% of patients, and the chance of tumor coming back in those patients is largely dependent on the amount of tumor that is removed at the initial surgery. If all of the tumor is removed, so-called optimal debulking, then you're closer to the 50% chance of that tumor coming back. And if there is a lot of tumor left behind at the end of surgery, even though that initial chemotherapy may make that tumor disappear, it's a much higher risk that the tumor is going to come back as high as 80%. The first sign of tumor recurrence is often a rise in the CA-125 tumor marker, and you will have certainly learned a lot about the CA-125 tumor marker, which is elevated in up to 80% of women with ovarian cancer. And many women actually worry a lot about what their CA-125 level is, and I'll spend more time here and in a subsequent talk talking about that. But even if the CA-125 goes up, even though this may be the first sign that the tumor is coming back, it does not always require immediate treatment. And I think it's important for you to focus on that fact that a rising CA-125 does not necessarily mean treatment, and point in fact is there are sometimes small rises in the CA-125 that don't even necessarily mean that the tumor is going to come back. Why is it important to know about the time interval between the end of the initial chemotherapy and the time that you are found to have recurrence of your tumor? Well, selection of therapy for recurrent disease is based on what we call the platinum-free interval. That is the time between the end of your primary treatment and the diagnosis of recurrence. So your primary chemotherapy ended at some point weeks, hopefully months, and occasionally years ago, and now the tumor has come back, and we break those recurrences down into two large groups. The first group, which is the vast majority of patients, have what we call platinum-sensitive disease. This means that there is 6 months or greater between the end of your initial chemotherapy and the time that recurrence is diagnosed. A much smaller group of patients have what we call platinum-resistant disease, and that's when the tumor tends to come back much earlier, in less than 6 months from the end of your primary chemotherapy. There's even a third group, which I haven't mentioned here, which we call platinum-refractory disease. This is a real rare occurrence, less than 10% of patients, but these are patients who do not respond even to the initial chemotherapy. Platinum-sensitive disease, the larger group of patients, is typically treated again with a platinum. The most frequently used platinum is the platinum that you most likely got as part of your initial therapy, carboplatin, and it is most often combined with another drug. It may be that the doctor will recommend exactly the same treatment that you got initially, that is carboplatin combined with paclitaxel or Taxol. But two other common drugs which may be added to carboplatin is a drug called gemcitabine or Gemzar, and as I go through this you're going to see two names. One is the generic name, and then the one in capital letters is always the trade name of the drug. And then there's a third drug called liposomal doxorubicin, known as Doxil, which may be added to the carboplatin. For platinum-resistant disease, the smaller group of patients, this disease is typically treated not with two drugs but a single drug, and never with platinum, because these are now patients that we believe are resistant to platinum therapy, and therefore we're not going to use platinum therapy. And there's some 17 drugs that may be chosen. I'm going to list those drugs for you later on, but deciding which of those drugs to use varies from patient to patient and physician to physician, and it's probably more than I can talk about in the time that we have to discuss this today. Let's first talk about platinum-sensitive recurrent disease, the larger group of patients, those patients who have more than 6 months from the end of their initial chemotherapy to the diagnosis of recurrence. The choice of which carboplatin-containing combination to use, that is carboplatin with Taxol again, carboplatin with Gemzar, or carboplatin with Doxil, is often based on many factors, since each of those three regimens that I mentioned previously appear to be equally effective in getting the tumor back under control. And back under control typically is up to 50%, sometimes even higher than that. 50% of patients can be gotten back under control. And point in fact is, the longer the interval between stopping the initial chemotherapy and the diagnosis of recurrence, the greater is the opportunity that this second round of chemotherapy is going to put you back into what we call a complete remission, or disappearance of all the tumor. As some examples, if there is residual numbness and tingling, neuropathy, when the recurrence is found, then we typically don't recommend that second drug be Taxol, because if you get Taxol again, that's going to make the neuropathy worse. And if you've already got some neuropathy, we certainly don't want to give you additional neuropathy added onto that, particularly when there are two other possibilities that appear to be equally effective, either carboplatin with Gemzar or carboplatin with Doxil. On the other hand, if during your initial chemotherapy you had a major problem with blood counts, you need to have multiple transfusions, or your white count went down and you developed fever and had to be admitted to the hospital one or more times, then we may not recommend the regimen containing Gemzar, because Gemzar is particularly toxic to the blood counts, and specifically to the white blood cell count and to the platelet count. And so, as you see here, there is no specific two-drug combination that is used for the platinum-sensitive recurrence. It's important for you and the physician that is making the recommendation to talk about what toxicities you already have, or what toxicities you have from your prior chemotherapy, and try to avoid drugs that may cause that toxicity again. In the platinum-resistant recurrence, the choice of the agent is from a very long list, and I'm going to just run through these, but you can just see from the number of drugs here that there are a significant number of possibilities. Gemzar alone, or gemcitabine, liposomal doxorubicin alone, Doxil, another drug that has already been approved by the Food and Drug Administration for treating recurrent ovarian cancer is a drug called topotecan, also known as Hycamptin. And then there are a whole host of other drugs, pemetrexed or Alimta, docetaxel or Taxotere. This is a drug very similar to Taxol, but with some different toxicities. There is another drug called bevacizumab or Avastin. This is actually not a chemotherapy at all, but more of a drug that starves the tumor of its blood supply and has a totally different set of toxicities. You don't lose your hair, you don't have any problem with blood counts, you don't have any nausea and vomiting. The major side effect of this drug is high blood pressure that can usually be controlled with one pill a day. So this is a drug that is more commonly used to treat platinum-resistant recurrent disease, but is certainly not the only drug, and of all the drugs listed here is far and away the most expensive drug. Another drug similar to carboplatin is cisplatin, but it is listed as a drug that can be used to treat platinum-resistant recurrence, although I personally rarely use this drug because if you're resistant to carboplatin, you're also very likely resistant to its big sister, cisplatin, and cisplatin has a whole lot more toxicity than carboplatin. There is a drug called vinorelbine or navalbine, which is an intravenous drug that has minimal side effects. Etoposide or Vepicid is an oral medication that is effective in some patients but does cause hair loss, and some patients prefer to avoid drugs that cause hair loss when their tumor comes back because they may have just recently regrown their hair and kind of like the way their hair looks. Nab-paclitaxel or Abraxane is a drug very similar to Taxol, but not necessarily ineffective even in a patient where Taxol has been ineffective. So there is no necessarily cross-resistance between the two drugs. Just because your tumor has grown on Taxol does not mean necessarily that a drug similar to Taxol will not be effective. Capecitabine or Xeloda, another oral medication. Hexamethymelamine or altretamine is another oral medication. Cyclophosphamide or Cytoxan, another oral medication. Phenylalanine mustard or Alkeran, another oral medication. So these are four additional oral medications in addition to the etoposide or Vepicid, which you may elect to do simply because you generally feel well and you don't particularly want to be coming into the clinic every week or every other week or every third week to get intravenous chemotherapy. Drugs similar to carboplatin and cisplatin, but which kills cells in a totally different way, is a drug called oxaliplatin. And just because the tumor is resistant to carboplatin does not necessarily mean that your tumor is resistant to oxaliplatin. A drug called ifosfamide or Ifex, rarely used because of toxicities associated with that drug. And irinotecan or Camptazar is a drug very similar to topotecan or Hycamptin, the same class of drugs, but occasionally used to treat recurrent ovarian cancer. So in terms of selecting an agent, I think it's important for you to understand that all of these agents, I think there are 17 of them up there, each has around a 20-25% chance of controlling your tumor. May not make the tumor go away completely, but will certainly stop the tumor from growing and oftentimes shrink the tumor. The choice of which drug to use may depend on the side effects of each drug, and as we've discussed before, you want to avoid pre-existing toxicity. So, for example, if you had a large problem with neuropathy from your original chemotherapy with carboplatin and Taxol, you would want to avoid using drugs that cause neuropathy. Some of those drugs would be nab-paclitaxel or Abraxane, cisplatin or platinol, and oxaliplatin. So the platinums, as a general rule, are drugs that cause neuropathy. If you had a significant problem with blood counts, then you would want to stay away from drugs that have a more profound effect on blood counts, such as possibly topotecan, possibly Gemzar. And I'm not going to go into all of this, but it's important for you to sit down with your physician and discuss all of the options. One other thing that may be important is the schedule of administration and patient preference. As I said before, there are about 4 or 5 drugs up there: topicide, capecitabine, hexamethymelamine, cyclophosphamide, and phenylalanine mustard, which are all pills, oral medications. And you may say, look, I'm having a good time, I'm spending time visiting my grandkids, I really don't want to have to come into the clinic every week for blood counts and to get drugs infused, and I'd like to get one of the oral medications. So these are things that are worth sitting down, spending some time with your physician, and talking about not only the side effects of the drug and which ones you're willing to put up with, but also how many times you're going to have to come in every month to get the drug administered. Some of these drugs are administered every week, and you may want to avoid drugs that require your coming in multiple times each month. And then finally, I want to just mention some of the assays. There are a number of these: Caris, Foundation One, Precision Therapeutics. These are all assays which purportedly or supposedly can help you select a drug that your tumor is more likely rather than less likely to respond to. None of these assays are yet totally vetted, meaning that it's not quite as simple as you have strep throat and they culture the bacteria out on an agar plate and put antibiotic discs on and can say categorically that your bacterial infection is sensitive to drug X but not to drug Y. They're not that specific, but they may be better than just closing your eyes and pulling a drug off the shelf, and you've got 17 drugs to choose from. So you may want to at least talk to your physician about sending some of your tumor tissue, and this does not require fresh tumor tissue. It can actually be the tumor tissue from your initial surgery that they can actually do some special studies on that may help to predict drugs A, B, and C are likely to be effective and drugs X, Y, and Z are unlikely to be effective. So it's at least something that you should at least sit down and discuss with your physician. I want to end by pointing out that recurrent ovarian cancer is a chronic disease. The patient with recurrent ovarian cancer should not consider this as an immediate death sentence. As you've seen, there are a lot of drugs with the ability to control the disease, and many patients live for months or even years with recurrent ovarian cancer in a very, very functional status, working full-time, if you're retired, traveling, seeing family, et cetera, and receiving intermittent chemotherapy when the disease is active and causing symptoms, but also having periods when the disease appears to be under reasonable control and periods when you're not getting chemotherapy, which we affectionately call a drug holiday. And I think it's important to always keep in mind that there is nothing wrong with saying, I'd like to stop chemo, the disease seems to be controlled, I feel fine, I'm not having any symptoms, let's stop chemotherapy for a while, and maybe in 2 or 3 or 4 months the disease is causing me a new symptom, and I'm happy to consider going back on one of these multiple single agents at that point in time, but it doesn't mean you have to be on chemotherapy for the rest of your life. It is important for the patient with recurrent ovarian cancer to continue to live every day to its fullest, as you would with any chronic disease such as diabetes, emphysema, arthritis, heart failure, or kidney failure, all of which are also non-curable chronic diseases. I think this is important for you to consider when you get that news, which nobody likes to hear. Your ovarian cancer is back. Again, this does not mean that you're going to be dead in 6 weeks or 6 months or sometimes even 6 years. There are people who live very functional lives for long periods of time because of the large number of drugs that are out there that are effective in treating this disease. Discuss all of this with your physician and always look forward and realize that this is really a chronic disease and not something that's going to take your life in the next few weeks. Thank you.